Welcome to today's webinar about oral immunotherapy and eosinophilic esophagitis, also known as EoE, featuring Dr. Punita Ponda. My name is Jennifer Roeder. I'm a communications consultant for APFED, and I'll be moderating today's webinar. We are pleased to have Dr. Ponda join us today. She's a pediatric allergist and immunologist and the founder and director of the Food Allergy Center at Northwell Health. She has a personal research interest in the study of tolerance to food and aeroallergens, including how it relates to eosinophilic esophagitis. Welcome, Dr. Ponda.
Thank you, Jennifer. I appreciate it. So we're going to get started, and I'm going to go ahead and share my screen. So as Jennifer mentioned, we're going to talk about oral immunotherapy and eosinophilic esophagitis today. I've done the presentation to include a structure that will cover both, and hopefully we'll have some time at the end to ask questions or answer questions. These are my disclosures. No financial relationships, but I'm a PI on several clinical trials listed here. Our learning objectives today are that at the end of the presentation, all of you should be able to know what oral immunotherapy is, describe the ideal person or persons that would be helped by oral immunotherapy, and then be able to be familiar with the benefits and the risks of performing such a treatment. And of course, eosinophilic esophagitis as a possible association with oral immunotherapy. So going first into the prevalence of food allergy, 32 million Americans have food allergy. That's 1 out of every 13 children under the age of 18 in the US that have food allergy. That means that about 2 in every classroom is likely to have a food allergy. And the perception by the general public, though, is that there is even higher prevalence. When the public is asked, about a quarter to almost a third will say that they have a food allergy. What are these people allergic to? Well, that depends on what we as a society eat and how we cook these foods. So, for example, the allergens in Europe are slightly different than the allergens in the US. And they're different than the ones that might be there in China. But clearly, the prevalence of food allergy in general in the US has been increasing. This is data from the CDC, and that was released in 2013. And it noted that between 1997 and 2011, there was a 50% increase in the prevalence of food allergy. So in today's talk, I would like to first go into speaking about what I mean by IgE-mediated food allergy, what other things can come as part and parcel with food allergy, and how can we manage this food allergy. We'll talk about how to avoid the food allergens, and then the other treatment that is of topic today, oral immunotherapy. We'll talk about the risks and the benefits, and of course, the complication of OIT, which is EoE. So going first into what is IgE-mediated food allergy. This is a simplistic cartoon where a food is ingested, say milk, the food gets digested in the gastrointestinal tract, and that causes proteins to be exposed to the immune system. Those are the antigens, the things that the immune system recognizes as either foreign or something that needs to be reacted to. And some of those food proteins enter the bloodstream as food antigen. And after they enter the bloodstream, special cells, they are called allergen processing cells, or antigen presenting cells rather, they will have a response to that food allergen. And it can be either a non-IgE mediated response where your T cells produce certain cytokines like IL-4, 5, and TNF, which are going to lead to responses that we call non-IgE mediated. And there will also be a response to the food antigen that comes into the bloodstream by B cells, which produce the allergy antibody, the IgE antibody. They recognize the food and they produce antibodies that are specific for that food. And those food allergy antibodies in the IgE mediated process then cause some immune cells, such as mast cells, to degranulate or have a reaction when a food allergen that has the allergy antibody present in the person is seen. So when the person eats the thing that they're allergic to, the antibody is present in the body, it recognizes the food and causes an allergic reaction that leads to the production of things that cause the allergic reaction, like histamine and other chemicals like leukotrienes and prostaglandins. So that's the general gist of what happens in the immune system processing of things. What are we allergic to? In the US, the most common food allergens are milk, egg, wheat, soy, peanuts, tree nuts, fish, shellfish, and sesame. Patients who are food allergic are more likely to have other associated problems, such as having eczema, or often called atopic dermatitis. They're much more likely to have asthma. They're much more likely to also have seasonal allergies or hay fever or rose fever, as some might say. Those are all what we say are atopic diseases, which can go together. One person does not need to have all of those diseases, but if there is one, the others are more likely to happen. What happens when this person eats a food that they're allergic to? Typical symptoms of food allergic reactions can be varied. Here in this slide, I've broken this up into various body systems, and 90% of reactions that happen as a result of IgE-mediated food allergies will include something that is manifest on the skin, such as hives, getting flushing or redness of the skin itching, or having some type of swelling on a part of the body. Those are all in the dermatological or skin system. About 30% of people will also have or can have gastrointestinal symptoms, which can include vomiting, nausea, pain, cramping, diarrhea. Respiratory system is the next manifest system that is noted in allergic reactions, which can include cough, wheezing, shortness of breath, and that's the lower respiratory system. In the upper respiratory system, it can also include sneezing, runny nose, congestion, itchy eyes, red eyes. In the cardiovascular system, people can have more severe reactions with dropping the blood pressure, feeling dizzy, faint, or passing out. And nonspecific symptoms such as impending doom will also be sometimes associated with allergic reactions. And in young children, irritability or lethargy is often noted as symptoms that are nonspecific, but due to an allergic reaction in the appropriate setting. When a person has a severe allergic reaction, which is life-threatening in nature and is acutely present right after eating a food within a couple of hours or less of eating that food, we call that anaphylaxis. And typically more than one body system is involved, or one body system that can lead to life-threatening reactions is noted. So that's how an allergy reaction can present, and the immune system responses that lead to the recognition and the symptoms that we note in allergies. Well, what do we do about it? So treatment options classically are either avoidance, which is the classic way that allergists have always handled food allergy. And it typically means complete avoidance of the food, including reading labels to avoid the food that the person is allergic to. Luckily, there are laws, food allergy labeling laws, that in the US require the recognition and labeling of the 9 major food allergens that we mentioned. And in 2021, that has now included sesame as one of the foods that is labeled on the packages of foods that we buy in the US. One exception to the complete avoidance recommendation is people who can tolerate baked goods that may contain egg or milk, because there are people who will be able to tolerate well-cooked, i.e. baked egg or milk, say in a muffin or cupcake, for example, but will not be able to have unheated milk or lightly cooked egg. One of the questions that we often run into and is quite common in practice to hear is, do the advisory labels, like the may contain label, do they warrant different risk levels? Does may contain versus shared equipment label, is that different? And the short answer is probably not. When the studies were done for looking at the comparisons of these labels, it was found that there was the food allergen that was in question was commonly present. And 7% of products that had a peanut may contain label had the product when checked, and up to 42% for milk. So that's quite a lot. And not much of a difference was there between one label versus another. Places to watch out for cross-contamination are when there are buffets, ice cream parlors, bakeries, and places that share their equipment. Those are common places where food allergens can have cross-contamination. When we diagnose a person with food allergy, we give them an action plan based on the history, the risk factors that they have, and the symptoms they've had in the past. And this is renewed yearly, or when there's been a significant change in the history or allergens, or in the person's weight or other risk factors. The treatment of anaphylaxis is epinephrine and usually dispensed as an autoinjector. It's the only treatment for anaphylaxis. Antihistamines will not stop anaphylaxis. And studies have shown that it is best to have 2 doses of the epinephrine autoinjectors available, because it was found that about 6 to 19% of patients, children, required a second dose to be administered during anaphylaxis. And the hallmark of success on treatment is recognizing anaphylaxis early and treating early by epinephrine. For patients who have food allergy, some tips for travel or in school are to always carry your autoinjector. More than 1/3 of reactions are noted when the person is outside of their home, i.e. in a restaurant, for example, and up to 18% or so have been reported to occur in daycare or in the school setting. So in addition to avoiding, just the diagnosis of food allergy is associated with a significant decrease in the quality of life. Children who have food allergy are often subject to bullying at school, in the playgrounds, etc. A lot of the patients who have food allergy may benefit from mental health support as well, because there are various challenges that include anxiety, difficulty in coping with and management of avoidance, and especially for young children, family challenges. A food allergy diagnosis often is a diagnosis for the whole family, not just for the person. So given all these factors and thoughts and the increasing prevalence of food allergy, even though the classic treatment options of avoidance were used for decades, the thoughts of oral immunotherapy were noted in the food allergy community. Just a little anecdote, the thoughts were probably noted because there was cultural differences in exposure to food allergens, both in young life and just in general. And that's one of the ways that the thoughts of oral immunotherapy, or OIT, were developed. Basically, oral immunotherapy involves the initiation of exposure to the food allergen the person is allergic to in multiple doses on day one, and then exposure to that same dose on an everyday basis while the patient is at home at that same level, and every, say, weekly or bi-weekly, dependent on the protocol one is using, that dose is increased in a monitored setting. So, for example, in our office, we have day one where the person is there for several hours, and we give them tiny minuscule doses and increase them every 20 to 30 minutes to get to a point where it gets to a dose that is able to be administered at home. And then that person eats that food every day at home. And every 2 weeks, we do our updosings every 2 weeks. The person comes into the office and we give them a slightly higher dose. And this goes on until you reach a maintenance dose. Once you reach the maintenance dose, you keep the dose the same on a daily basis. And that's the process of desensitization, to take away the response to the allergen that the person is being responsive to. After that period, some of the studies have discontinued the food and seen whether the person is still allergic, or was this a treatment that lasted for benefits beyond that initial treatment path. So you'll see me mention the words sustained unresponsiveness after discontinuation. And the basic thought in this desensitization process is that, going through that same cartoon, that even though the food enters the bloodstream and is responded to by antigen-presenting cells, the IgE-mediated process doesn't happen. And if it happens, it is at a much lower level. That's the thought behind the process. This is a complicated slide, not going to sort of belabor the details, but basically what I want to show here is that you start off at baseline with having cells that recognize the food. With exposure over time, those cells decrease, and other cells like regulatory cells increase that decrease the response of the allergy cells, and in some cases produce antibodies that will block the response. So what's noted is, over time, the allergy antibody to that food is likely to go down, and the antibodies that are the beneficial antibodies will go up, and the memory of that recognition of the food allergy is likely to also go down or not be increased. So does this process work? And the most knowledge is known about peanut. This is from a study for product that is now on the market, and it was a process and clinical trial that led to its approval. What this figure shows is that at the 22-week mark of treatment with the peanut dosing every day, the patients who had initial reactions to getting about cumulative dose of 144 milligrams of peanut, which is equivalent to around 1 peanut, when they were given peanut in higher amounts than that, most of them were able to tolerate a higher amount after the 22 weeks of exposure than they were before, and definitely more than the people who got placebo. So if you were given peanut every day versus placebo, the people who got peanut were able to tolerate higher amounts of peanut when they were challenged at week 22. Not only this, but the people who completed the process of the desensitization, when they did have reactions to the additional peanuts that were given on the day of the challenge, they were less likely to have severe reactions. Here, the red represents the severe reactions, the green represents the no reaction, and the light blue represents mild reactions. As you know, in the people who completed the process, most of them had no reaction, none had the severe reaction for the most part, and more had the milder reaction. All of these studies then led to the approval of a product called malforzia in January 2020, which is approved for children who are between the ages of 4 and 17. It does come with risks, though, which we're going to talk about next. And so the FDA required that we have a process called REMS that talks about mitigation of those risks. And it stands for Risk Education and Mitigation Strategy. Meanwhile, in this cohort, it was asked that peanut ingestion be avoided in larger amounts, and that for this product, it was for cross-contamination exposure, not leading to reactions. So what are the risks of OIT? Well, when the study that I mentioned that led to the approval of the peanut product were looked at, it was found that most people had mild to moderate reactions. So those are listed here. And there were episodes of anaphylaxis that were noted, but those were fewer. Going particularly more in detail to the side effects that were noted, it was noted that the GI side effects like abdominal pain, nausea, vomiting, etc., were the most common reactions noted. In up to 66% of people, there were some type of GI reactions reported. There were also respiratory reactions, such as 48% that reported some type of respiratory symptoms, whether it be cough, discomfort of the upper airway, the runny nose, sneezing, etc. Looking further in more detail at who should be getting oral immunotherapy, it was found in a study that had 270 preschool children that 90% of children who went through this process were able to be successfully desensitized, and they tended to have fewer reactions. As you can see, just the reaction rate is a little bit less, and there was less use of epinephrine. Although as the numbers increased, as this graph shows, the higher the number, more likely to have more reactions, but overall success rate was pretty good. It was also found that younger children were more likely to complete the treatment in comparison to older children. And other studies have also looked at the fact that if oral immunotherapy is started before the age of 4, there may be some increased success of the desensitization and achieving remission. So this brings us to the thought of who an ideal candidate might be. Well, any age person can go through the process, but some studies have shown that younger people may be easier to desensitize, or it may be more effective in them. And the goals may be different. The older children may want to have cross-contamination protection, kind of like with malforzia, where doses are achieved up to protection that would give you lack of reaction or milder reaction upon accidental exposure, but those children can't eat peanut butter and jelly. So depending on the goal of the process and the level of desensitization that's needed, the appropriate age group might be considered. People who've had particularly severe reactions may want to consider other options that hopefully will become available in the future that are not through the oral route, or if they are going through the oral treatments, then the doses that are achieved may be particularly tailored to them, and the updosing strategy also may be different. This is a time-consuming process, and an ideal candidate would be someone who's motivated and may even have had other effects from their life or quality of life that is diminished by food allergy, and they're motivated. They're motivated to change that, and they're willing to devote the time to do it. An ideal candidate should also be knowledgeable about recognizing their limits and recognizing reactions. And when that happens, to seek treatment and or administer treatment as appropriate. And overall, after knowing the risks and the benefits of the process, an ideal candidate would have open eyes about what the risks and the benefits are, and be willing to say that the benefits are outweighed by the risks of the process that come inherently with this. So who doesn't qualify? So if a food is being avoided for a non-IgE mediated allergy, such as if a person has EoE, or a person has FPIES, which is food protein induced enterocolitis syndrome, or other non-IgE mediated food allergy, that person is likely not a good candidate for oral immunotherapy. Why is that? Well, going back to this cartoon that we talked about, once the food is digested, it enters the bloodstream. With oral immunotherapy, you may be able to affect the IgE-mediated process. You're not doing all that much for the non-IgE-mediated process. So if your problem with the food is manifest with non-IgE-mediated food allergies, oral immunotherapy is likely not the right treatment for you. What other things should one think about? So if you've had severe reactions in the past, if a person wants to does not want to continue the food that is being desensitized, that's probably not a person who should go through that process of desensitization and take up the time and the effort when they're not going to continue to eat the food, because as we mentioned, if the person stops eating the food, the likelihood of sustained unresponsiveness may be relatively low depending on the food. If a person has uncontrolled asthma, that person must be careful. As you saw, there were significant amounts of respiratory reactions that were noted when one goes through oral immunotherapy. And so to address the asthma before this is considered, excuse me. If a person has other medical problems that make oral immunotherapy a particularly high risk procedure, that person really should think carefully, and their doctor should think carefully about considering oral immunotherapy. And of course, if a person is pregnant, that probably is not a good time to do this process. So we're going to then speak specifically now about oral immunotherapy and eosinophilic esophagitis. This is a graphic abstract from a recent manuscript that looked at people who had oral immunotherapy and their likelihood of developing eosinophilic esophagitis. So these were people who went through oral immunotherapy to either milk, peanut, or egg, and it was found that about 2.8% of all people who went through oral immunotherapy developed EoE. The most likely was milk OIT, which had a 3.9% likelihood of developing EoE in that cohort. And in just general and other studies, there's somewhere between a 2.8 or 3% chance to about a 5% chance of that occurring in through the process of oral immunotherapy. And the commonly reported symptoms were listed here, and I'm going to go into them in the next slide too. So the most common presentation is often abdominal pain, difficulty swallowing, or pain on eating. A person may develop nausea or vomiting. And there's a time association with when oral immunotherapy starts if the oral immunotherapy is the trigger for the EoE. There's two different types or presentations. One is soon after starting oral immunotherapy, and then after reaching the maintenance or doing OIT for years. The second, the ones that have been doing OIT for quite some time and have then been diagnosed with EoE, that is thought to be more likely due to the trigger food that is being desensitized. In the first case, when it occurs soon after starting OIT, there's some debate about whether there might have been the subclinical presence of EoE, and it was just manifest during the process of desensitization. So what happens when this does occur during oral immunotherapy? Often the recommendations are to stop OIT. The study that I mentioned that I just showed you the graphic abstract of, in that the early onset cohort for EoE, a fair number of them were able to continue OIT and the symptoms resolved, but more to come on this management strategy as the studies come forth. But those are some possibilities of what might be recommended if this does happen during oral immunotherapy. So in summary, we have talked about the fact that desensitization is achievable in most people that have IgE-mediated food allergy. Sustained unresponsiveness, although may be possible, it's not typically a cure, so that is not something that one would depend on. And there are real risks to this treatment pathway. And we have the most knowledge about peanut, and there's an FDA-approved product for cross-contamination protection that is available. And there are many foods that this has been also reported to be successful for besides peanut. There might be a window of time when the child is younger to act, more to come on that as the studies become available, but that might be true in the future. And again, this is not a treatment for everyone. It should be discussed, and there should be a shared decision with you and your doctor playing a role in the final outcome. So today we've talked about what IgE-mediated food allergy is, what other things can present with food allergy, how to manage, or how typically food allergy was managed, either with avoidance and more recently with oral immunotherapy. We've talked about the benefits and the risks of oral immunotherapy, and we've talked about EoE specifically as a complication of oral immunotherapy. And that's it. Any questions?
Thank you so much for the wonderful presentation, really going through the whole process to understand the many aspects of this. So we've got a number of really good questions coming in. So thank you to everyone who's already submitted them. Please feel free at any point in time as we're having this discussion now to go ahead and type in your answer in the Q&A box, and we'll try to get through as many questions as we can here today. So when someone, there are many different aspects of your presentation today that we're getting some great questions for. First question is going to be, what foods is oral immunotherapy available for? You've talked about peanut. What other ones might someone be treated with that?
Sure. Theoretically, it could be done for any food. The protocols and the most common needs that have come across are, of course, peanut, and the most research is done for peanut, but taking from that and going to other foods, there has been successful oral immunotherapy that's been done for eggs, for milk, for wheat, for soy, for other nuts. Pretty much most foods can be tackled with the right planning and the basic premise is you start with subthreshold doses of the food that the person is allergic to, and you carefully increase the dose, and the exposure needs to occur daily. That's the basic tenet of what the process taught us. The food allergen involved, they're different, and there might be different levels of success with the treatment and the food and the person, but theoretically it could be managed with most foods.
You mentioned during your presentation that if someone has EoE, that they possibly, or that it's not helpful to desensitize people with EoE to their triggers. If someone has an IgE-mediated food allergy and is already diagnosed with EoE, how does that play into oral immunotherapy?
Yes, that gets complicated because one aspect is the IgE-mediated food allergy and whether that in itself can be a trigger for the EoE. And if the person is already avoiding that food when the EoE was diagnosed, that's likely not a trigger for the EoE because it was never in the diet for that person to develop the EoE from it. If a person has an IgE-mediated food allergy and that's also a trigger for EoE, then that clearly is not going to be successful. That's not something that would be able to be desensitized because it will trigger the EoE. For the first case, when an IgE-mediated food allergy is not the trigger for EoE, that's something that I think partnering with the GI doctor and your allergist with a conversation can be considered, but it would be high risk and it would be a complicated process because as you saw, 3 to 5% of people will just develop EoE as a result of the oral immunotherapy. So if you go through this process and it exacerbates your EoE, it can complicate the underlying disease. So it should not be taken lightly, and it is a big consideration. And for most general reasons, EoE is a contraindication for going through oral immunotherapy.
In the beginning, you also talked about food labels. If someone is avoiding a food for EoE, not a food allergy, not anaphylaxis reasons, should they be avoiding foods with may contain statements?
We typically say that the may contain statement containing labels if the exposure occurs on a very intermittent basis and it's because of EoE that you're avoiding the food, that is okay. But I would speak to your specific GI doctor because there can be differences in the level of sensitization and how often you're exposed to that food. So for example, if milk is your trigger and you're eating a food that has a may contain label and 42% of the times it's going to have milk and you're eating that every day, well, that may not be okay. But if you are going to a birthday party and you're going to eat a food on the special occasion on just that one time, that may be okay. So there's a lot of gray in there, and speaking to your doctor specifically about that would be important.
I'm filtering through all the wonderful questions that are coming in here. If someone is going through oral immunotherapy, can you just reiterate for us what the key signs or symptoms are that someone might talk to in terms of those contraindications that EoE might be developing?
Sure. And those would be more GI symptoms like abdominal pain, pain on swallowing, vomiting, nausea. Those are the typical symptoms that one presents with. And typically it's not just on a rare occasion, which may happen to a lot of people, but this is a more consistent complaint that the person has while going through oral immunotherapy.
Are there any questions you recommend people asking their doctors if they're considering oral immunotherapy and they do not have EoE? Like, are there risk factors that have been associated with it developing?
Not as far as we know that I can kind of put out there. Certainly people who have lots of atopic conditions, they have the food allergy and the asthma and the eczema and, the whole gamut. You should be speaking to your doctor about the risks and the benefits of treatments. If there's a family history of EoE, for example, and you're going through oral immunotherapy, whether there should be a higher level of vigilance for these symptoms. And when these symptoms do occur, if they occur, that you go see the GI doctor or consider EoE in the differential sooner rather than later. Those are some of the things that can be patterned to each individual person.
So a follow-up question that some people are asking are, should patients have an endoscopy to rule out EoE before they start oral immunotherapy?
So that's a very interesting question because it's been considered in the allergy community for a long time, and logically doing something before, going through the procedure, and then you would know the answer whether it was there before you started, seems logical. And there are studies that have done that on a small scale. There are no major large studies that I can refer to that had everybody get scoped and then do oral immunotherapy and then have scopes after, because doing the scopes have inherent risks. It's an invasive procedure, young children and going through anesthesia that has its own risks. So most clinical scenarios, that has not been a practical approach that people have used. But if you didn't have to worry about it and you could just kind of snap your fingers and just get the answer, that would be the way to get the answer. Absolutely.
Okay. Some people are asking also about symptoms beyond GI when they're having oral immunotherapy that might be indicative of EoE. And I guess maybe perhaps you could provide some distinctions of the different areas of the GI symptoms, GI tract that people could be having symptoms. For example, someone's asking about heartburn. Is that a warning sign as a side effect of OIT that EoE could be developing?
So heartburn itself comes from different sources. So reflux, for example, is not necessarily the hallmark of EoE. However, they do coexist. So if this is ongoing heartburn or ongoing reflux a person is having, you should talk to your doctor and see what they can suggest to do about it. The other symptoms that young kids have been known to present with that is not specifically GI related is coughing. Interestingly enough, sometimes children will have cough as the manifestation, say when they're eating. And that is something that if you notice, basically, I think just to generalize, if you're noting specific symptoms that are occurring as a result of an OIT process and treatment, bring it up to your doctor. What's the worst that can be? That you're going to bring up something and they're going to say, oh, it's nothing. Well, then, okay, now you feel better. It was really nothing. But if you don't bring it up, it's something that you missed an opportunity to tackle. So if something is occurring consistently, whatever that may be, and it's an association with going through oral immunotherapy, bring it up to your doctor.
What can you share with us about medication treatments during OIT? For example, budesonide, Dupixent, other things, like how do they play into each other or against each other?
There's a lot of interest and a lot of effort that is going into addressing those combination processes as we speak. There are studies that are being done and have been done, as you mentioned, with Dupixent and oral immunotherapy. There's studies that were done with Xolair, which is an anti-IgE treatment, and oral immunotherapy, and various other combinations. There's recently a study about probiotics and oral immunotherapy. That data is coming in, and there is nothing specific that I will tell you about because we're still in the process of learning that information. But what I can generalize and say is that there may be a role for, say, a biologic or some enhancing treatment to make, say, the side effects of the treatment better or the efficacy of the treatment better because you're able to achieve higher doses safer. So there certainly is lots of effort and work that is being done to address those other things that may be successful in making oral immunotherapy more palatable and more usable for people.
So I know your expertise is in the pediatric world, but we have some questions also coming in. If perhaps you can comment to them or point us to some resources of are these treatments also available for adults? We're talking a lot about how they work for kids.
Sure. So it's interesting that you say that. Yes, I do see adults. And so the studies are often done in children because the prevalence of food allergy in children is higher than adults. But theoretically, these types of treatments can be used for adults too. The process is likely to be similar of desensitization in adults as well. So depending on your access to the various healthcare providers by where you are, that should be discussed with them. There is no FDA-approved product for adults, so that will give some of the allergists and other doctors some pause. But in general, the process of desensitization and tolerance of the immune system, the cartoon that I kept going over, is going to be very similar in adults too.
Thank you.
Sure.
Another condition people are curious about the overlap with is Barrett's. Is there any relationship between oral immunotherapy and Barrett's, or even between EoE and Barrett's?
The short answer to that is we don't know for the first one, i.e. oral immunotherapy and Barrett's, because oral immunotherapy itself is a relatively new process, and studies, as we keep saying, are ongoing. And so that may be something that gets studied in the future. For the second one, EoE and Barrett's, there's data that this is controversial. So in the GI world, there is a lot of debate about whether EoE can be a precursor for Barrett's or whether they're two separate entities. So I'm not going to specifically, comment on that, but to say that it's a great question, and we are looking, or the GI doctors are looking into the answers, but there's nothing specific that I know of to tell you about that.
That's helpful. Thank you. We recognize there's still a lot of opportunities for research and unanswered questions. So recognize that as many answers as we're hoping for, there are not answers to everything yet.
Absolutely. Well said.
Circling back to kind of the balancing act between oral immunotherapy and EoE, if someone has a really life-threatening allergy to peanut, should that be treated, should the OIT be a priority in treatment over EoE? They're saying, for example, can EoE be treated with medications while going through OIT?
So that's a personal decision. And the difference in quality of life is going to be specific to each person. And I'll give you an example. So person A has a life-threatening allergy to a food that is not very commonly encountered in their life or in the world around them, kind of a very rare food. But they have EoE that is triggered by milk, egg, wheat, some of the most common foods in most people's diets. Well, it would depend on that person's priority as to what should they address first. Their quality of life may be more affected by one or the other. If they're able to control their EoE by, say, swallowed steroids, or now, for example, Dupixent is on the market for the right age group for EoE, and then they are not as concerned about the EoE triggers and then focus in on that food allergy, yeah, absolutely, that's a consideration. But remember that complication of having IgE-mediated food allergy and EoE going through the OIT process, it's not recommended. I mentioned that you might want to speak to your GI doctors and your personal doctors in case they want to do things differently, but that's just on a case-by-case basis. A particular shared decision process might occur, but in general, EoE is a contraindication for oral immunotherapy.
Flipping things on their head a little bit, can elimination diets make someone more prone to developing an IgE-mediated allergy response to a food?
That's a tough question. There's no perfect answer. I'll give you my opinion, and keep in mind that's just my opinion. For the younger age group, learning from the LEAP and LEAP-ON studies and various other studies that have looked at early exposure to food allergens and continued exposure to food allergens in young kids and babies, it has been shown that if you avoid those allergens in young children, especially ones at high risk, like the ones who have, severe eczema and so on, those kids, if you avoid the food, are more likely to become sensitized. So in the younger age group, I would tend to say, yeah, exposure and continued exposure is helpful in not developing a sensitization. For older individuals, for adults, for example, we don't quite know the answer to that. What we do know is if you keep the food in the diet, you are unlikely to become sensitized to it. So whether we can comment the converse, if you don't keep the food in the diet, you're more likely to develop the allergy. That's probably true, but we can't say that for sure because the studies haven't been done to address that. And they're hard studies to do.
Say lots of ideas for studies. Sorry, I seem to be echoing a little bit there, but it seems like there's lots of ideas for more research coming out of our discussion today. Well, thank you so much. Is there anything else based on the questions that have come up that you'd like to share today?
No, this was a great discussion. I'm glad that there was interest in continuing the conversation further, and there were great questions, so many of which, like you said, don't have answers yet, but are therefore great questions to be addressed in the future. So looking forward to progress on both fronts, treatment of food allergies using oral immunotherapy and or prevention, as well as EoE, hopefully more progress there too.
Wonderful. Well, thank you so much for your time today and all your insights and the research you did to put together today's presentation. Thank you also to our education partners for their support of this webinar series, including Abbott, AstraZeneca, Bristol Myers Squibb, GSK, Sanofi, and Regeneron. We hope you will continue to join us for future webinars. If you're interested, please check out apfed.org/webinars. We do have another webinar next week. You can join us to learn about the natural history of pediatric onset eosinophilic gastritis on Thursday, December 15th. More ways to continue learning include checking out APFED's annual patient education conference. EOS Connection 2022 was held virtually, and so the sessions are available on demand for another few weeks, just till the end of the year. Another great way to continue learning is to tune into and subscribe to APFED's podcast, Real Talk Eosinophilic Diseases. In the most recent episode, our co-hosts Ryan and Holly had a great discussion about being diagnosed with EoE as an adult and cooking with a limited diet with patient advocate Stephanie Ulrich. We hope you'll really enjoy the conversation. You can be able to find that episode at apfed.org/podcast, as well as on Apple Podcasts, Spotify, Audible, and additional places you might choose to subscribe to podcasts. If you'd like to make connections with other people experiencing eosinophilic disorders, we encourage you to continue the discussion in our online community on the Inspire Network. It's a great place to connect with patients and caregivers for support. Head over to apfed.org/connections to check it out. Thank you again, everyone, for joining us today for APFED's EOS Support Webinar Series, and for such a wonderful presentation today, Dr. Ponda. If anyone has any questions that didn't get answered today, please feel free to email mail@apfed.org. I hope everyone has a great day.
Thank you, Jennifer. Thank you for inviting me.
Thank you for joining us.